Thank you very much. So actually, I will be speaking for Nesrine Barnat, who could not make it. She applied for a visa in March, but did not get the answer, so she could not make it today, and we feel very sorry for her because she is driving this this study. So basically, venous insufficiency happens when the valves are dysfunctioning and do not prevent the blood flow from going down anymore. And so we have a reflux towards the foot. And as Michel mentioned, this can yield to different sets of insufficiencies, varicose veins, and go up to swelling, skin change, and ultimately to ulcer. The treatment options currently for venous insufficiency are stripping or sclerotherapy, phlebectomy, or thermal ablation, endovenous thermal ablation with RF ablation or laser ablation. We decided to investigate the thermal ablation and using focused ultrasound. But first, the effect of energy on the vein wall would first induce destruction or denudation of the endothelium, and then might induce a shrinkage of the collagen itself. This shrinkage might also induce fibrous reaction of the vein wall, and ultimately it might close the lumen. So the shrinkage of the collagen itself would lead to a vessel shrinkage, and this has been reported before by using other modalities such as RF or laser ablation. And in this case, so this shrinkage of the collagen can ultimately lead to a vein wall contraction. And we proposed in the first study to use the EcoPulse HIFU device from Theracleon to induce vein wall contraction and quantify it and measure the change in diameter. Shrinkage has been reported in the literature before, but it was not quantified. So we use HIFU to induce the shrinkage, and with ultrasound imaging, image the diameter of the vein. So 6 sheep have been sonicated. Pulse duration was 8 seconds in that case, and the acoustic power was 80 watts. And we used diagnostic ultrasound with the supersonic Explorer scanner to visualize the vein and measure the diameter before and after treatment. So here is an example of the contraction that we are able to see actually. So on the left is the image immediately after ultrasound heating, and you see the contracted diameter on the left as compared to the untreated vein. And on average, we observed a 75% diameter reduction immediately after the delivery of the ultrasound. And 30 days later after treatment, on the right, you can see on histology that we can also observe that the treated segment has a smaller diameter. And so 26 days, 30 days post-treatment, we see a 44% reduction in the lumen. So this first study was intended to investigate the shrinkage that can be induced by heat deposition with focused ultrasound. We were able to assess this change in diameter both during acute measurements, but also 26 days post-treatment. And in the next presentation, I will show you some histological characterization and the ultrasound effect on vessels and how to not only induce a shrinkage, but also go all the way through a complete blocking of the blood. And those 2 studies were meant to prepare the clinical trials that Michel Nuta presented you right before. Thank you.
Any questions? All right, I have a question. How much mean reduction is necessary for the treatment to be effective long term? So if at 26 days, a mean reduction of 44%.
So I guess it would be easier to answer to your question after the next talk, where we assess exactly how many in how many cases we were able to completely block the blood flow. But one important thing to report is that for RF ablation, actually those procedures are only meant to induce shrinkage. Mm-hmm. They don't claim to go all the way to a complete stop of the blood flow. So this is why it was important for us to do both studies. First, to show if we could induce a shrinkage, and I would say that would be enough to compare with competing technologies. And the second part is to actually try to induce a complete blockage.
Thanks.
So I suggest we move on to the next talk.
Good idea.
By Jean-François away from Institut Langevin.
By the way, I would like to thank a lot Nesrine Barnat, because she could not make it, and she was the one doing those two studies. This is the end of the first talk, so we need to switch to the other talk. Okay, thank you. So once again, I will, so this is Nesrine Barnat's PhD work in collaboration between Heraklion and Institut Langevin. So here we propose to use the EcoPulse HIFU device to occlude the veins. This is not the first time that high-intensity focused ultrasound was proposed to induce occlusion. The only thing is that most of those studies intended to occlude the blood flow in quite small diameter vessels, typically 1 to 1.5 millimeter. And most of the time, the blood flow was decreased, but it was not, they could not induce a permanent occlusion. So our goal was to evaluate the potential of high-intensity focused ultrasound to completely occlude veins with a diameter that was higher than 2 millimeter. We first performed some simulations with the K-wave simulation toolbox to identify the exposure parameters, and you'll see to change a little bit the trajectory in order to ensure to coagulate tissues over a volume that is enough to cover the 2 millimeter diameter of the vein. And then we performed in vivo experiments by using the same device. So with the pulse duration here was a little bit shorter, 4 seconds. And as you will see, we use two kinds of sonications, either fixed pulses or moving pulses. To induce the vascular occlusion, two phenomena might be at stake. First is vein shrinkage, as I explained before, and the second one is thrombus formation within the vein. Vein shrinkage is due to collagen degeneration, and thrombus formation is initiated by endothelial damage. To solve this, we did some tissue modeling and thermal modeling using the BioIT equation. And concerning the damage on the veins, because we do not have the thermal dose, we have it for several tissues, for brain, for muscles, for skin, but not for the vessel walls. But Agea, 20 years ago, actually published a paper where he was looking at vascular damage, typically, and we used his value for actually using the Arrhenius law to predict the damage that we would induce to the vessel wall itself. So we used two sets of pulses, so the vein would be along the horizontal axis, and if we use the Heraklion EcoPulse device with 80 watts during 4 seconds, this is the lesions that we would get. So for vessel diameters less than 1 millimeter, it's way enough to cover the entire diameter of the vein. But we wanted to treat veins up to 2 millimeters in diameter, so we might not be able to treat to induce complete coagulation, so that we actually removed the focal point perpendicular to the vein in order to enlarge the thermal effects and cover a larger diameter around the vein. So we performed those experiments with either single focusing, fixed pulse, or moving pulse on 29 rabbits. And here there are two examples of treatments that we performed, either with fixed pulses that were moving, of course, along the vein to treat over a given distance, and other treatments that were performed with moving pulsing. So 8 with moving pulses, 21 with fixed pulses. And we noticed, we were on the learning curve, and the best strategy to induce complete blocking of the blood flow is to compress the vein, to stop the blood, in order to decrease the heat sink effect of the blood and to increase the efficiency of the treatment. This is an example of blood flow reduction. You see a dramatic reduction after the sonications. And here, 15 days after the treatment, you see a complete stop of the flow in this case. So typically, this is the result we got with fixed pulse sonications. We see that a thickening of the wall, and in this case, a complete collapse of the lumen. And in some cases, we could also induce some complete occlusion with a large thrombus within the vein in that case. So not only a collapse, but also a thrombus within the vein. Total, with the fixed pulses, we've been able to completely occlude the veins in 80% of the cases, with the moving pulses in all cases, actually. And the lesson learned is that vein compression is important to ensure a good efficiency of the treatment. When we performed the study, the future work was to translate to clinics, which has been done since, and Michel just presented the results obtained with the same Theracleon device. I thank you for your attention. I thank my collaborators, and once again, Nesrine Barnat, who could not make it today. Thank you.
Question? Yes, please.
So I'd like to ask you about the future when translating to the clinic, because I'm not familiar with that. So if you occlude all the veins, then what happens? You stop blood flow, right?
No, yeah. So I guess Michel could address your question better, but so he was in charge of the clinical trials. That I don't know if you've seen his presentation.
So what we are occluding right now, it's what is occluded already with other thermal methods or surgically, but the other thermal methods are all endovascular. I don't know if you are familiar with a stripping. This means that you are getting with a wire inside the base and you are tearing it out. So the return of the blood is done by a collateral system.
Right.
But this is,
getting
rid of the varices, in fact.
Mm-hmm. So it's specific veins. It's not systemic. It's specific veins.
It's just the one that is
only on the veins and only in the lower limb. We didn't went to the vena cava.
Okay. Thank you.
My question is about the thermal simulations. How did you choose the contribution of absorption and scattering for the thermal simulation?
How did you choose what?
Contribution of absorption and scattering for the thermal simulation.
Oh, all those. Well, so first, in that case, so this is almost homogeneous tissue, and we took those values in the literature. I mean, as close as we could get. The thing is, we did not consider in our simulation the blood flow, and actually, it's quite close to most of the most successful treatments that we have had was with the vein compressed. So there was no blood flow. So we just consider basically in the simulation homogeneous tissues, and we look at the thermal rise, and we go well above actually the threshold for coagulation. So it was more for us a way to assess what is the typical size of one single lesion, and do we need to extend this lesion in order to achieve a 2 millimeter in diameter occlusion? And yes, we needed to extend a little bit. But absorption is not from measurements that we did. It's based on the Duck booklet, where you have all the thermal and ultrasonic properties of tissues.
One last question.
Just a hypothetical question. What would happen if you use anticoagulation kind of drugs while you're doing the treatment? Will it affect?
But the idea was to perform an ultrasound alone treatment, and no other drugs during the treatment.
But what would
you
happen?
mean if the patient has? I guess this should be.
So maybe I can answer this to you. If you are using anticoagulation, nothing will happen if you are heating the blood, because you are heating it at 85 degrees. What can induce an anticoagulation is the lack of extension of the thrombus at the end of the treatment. And for anticoagulation, if you are doing subcutaneous anticoagulation, you have to do it for 5 days in order to have an effect, and it is in fact used. It's a very good question. It is used for the other thermal ablation methods like radiofrequency, because these are risking to extend the thrombus in the deep system.
All right, thank you very much.